Great, welcome everyone. We're just, people are just coming in the room, so you are hopefully in the right place where you wanted to be in your Zoom rooms. We are at the Global Health Learning Network January session, and we are delighted to have our speaker, Dr. David Addiss, with us today. So I think we'll go ahead and get started just to make sure we've got enough time to have some discussion, some interesting discussion, and I'm really looking forward to today's session particularly. My name is Alison Krentel. I am an assistant professor at the School of Epidemiology and Public Health. I'm also a senior scientist at the Besoin Research Center and a member of the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity. And it's a pleasure to be here today to moderate this session. Before we begin here at the University of Ottawa, we want to pay respect to the Algonquin people who are the traditional guardians of this land. We'd like to acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. And I say that land acknowledgement today and just want to bear that in mind as we talk about compassion and global health today. So I think it's a nice way. We do start all our sessions that way, but it's particularly interesting in light of what we're going to be talking about today. So for those of you who are joining for the first time, the Global Health Learning Network is a platform for knowledge growth and exchange that has a goal to build a community of practice in global health that reaches researchers, practitioners, and learners from all global health domains. We welcome people from the University of Ottawa, from outside. Anyone can join, so we're delighted if you're joining us today, either from within the Faculty of Medicine or from outside. So I'm happy to have you here today. As part of the Learning Network, the webinar series is a collaboration between the School of Epidemiology and Public Health, the Besoin Research Institute, and the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity, and the International and Global Health Office at the Faculty of Medicine. So it's a pleasure for me to introduce our speaker today, who I have known for many years and who has been a mentor and a colleague and a friend. So I'm delighted that he agreed to speak with us today. And I'm delighted that you all have made time in your day to be here. Dr. David Addiss is the director of the focus area for compassion and ethics at the Task Force for Global Health based in Decatur, Georgia. After working in migrant health as a general medical practitioner, Dr. Addiss studied public health at the Johns Hopkins University and then worked as a medical epidemiologist at the U.S. Centers for Disease Control and Prevention. And there he focused on neglected tropical diseases, or NTDs, and co-directed WHO Collaborating Center on the elimination of lymphatic filariasis in the Americas. Dr. Addiss also directed the Fetzer Institute's research program in science and spirituality, and then led the Children Without Worms program at the task force. Dr. Addiss is an adjunct professor at the University of Notre Dame and the Rollins School of Public Health at Emory University. His current interests include the prevention of neglected tropical diseases, global health ethics, and the role of compassion in global health. So enough from me, and I would like to hand over to our speaker today. So welcome, David. Bienvenue, and thank you for joining us today.
Merci, Alison, and thank you so much to everyone who's joining and will be listening and hopefully challenging some of the ideas that I'll be presenting. It's really a joy to be with you. So I'll start by sharing my screen. And I do have slides to show and to walk through, and they'll be guiding our talk. But I encourage you that if I say something that's particularly needs to be challenged or needs to be commented on, please feel free to jump in and comment. And I may not be able to see our hand raised given the share screen, so feel free to jump in and just make yourself known, and we can stop at any point in the conversation, in the slides, and have a conversation. So I'd like to speak today about compassion. I consider compassion both a programmatic necessity for global health practice, but also it's a personal journey for each of us. I think actually global health is a pathway for us to become more compassionate and to deepen in our own understanding and practice of compassion. My own journey on this pathway was catalyzed by sitting in the admission office of this hospital in California with my mother towards the end of her life. She required blood transfusions every few days. And I noticed on the wall this poster, compassion. And I was intrigued. The hospital claimed that they reached out to people in need to give comfort, just as Jesus did. And I thought, well, that's a very high bar to set for the organization. And it wasn't necessarily evident to me that they were succeeding as we were going through the bureaucratic hoops of getting readmitted. I became curious about this use of compassion in clinical medicine. And one of the students that I worked with at the focus area for compassion and ethics did a survey and found that about 58% of hospitals in the United States mention compassion on their website. And you can see that there's quite a bit of geographic heterogeneity in that. And so it seems that compassion is promoted and advertised by clinical practice and clinical healthcare. I did a quick search, the University of Ottawa, and you too talk about the compassion and exceptional service and compassion that patients will receive at your institution. The Ottawa Hospital is a compassionate provider of patient-centered care. So not only do we promote technical excellence in clinical medicine, we also promote the aspiration, anyway, to deliver and express compassion. But in global health and in public health, this seems to be much less common. We have to listen carefully if we're going to hear the words compassion in a global health discourse. This is starting to change, and I'll be presenting some what I think are hopeful signs towards the end of the talk. I went through an exercise several years ago asking people, our colleagues, why in one word do you do this work? What motivates and sustains you in global health? And when our colleagues were willing to play that game and try to express one word that encapsulated this motivation, very often they would visibly soften and they would use words, almost whisper them, words like care or compassion or even love. And I would say that love was not a word that I heard in the halls of the CDC for 20 years. But when you ask people at for example, my colleagues in Leogane, Haiti, physical therapists working with patients with lymphedema, or colleagues at the Centers for Disease Control, or even at a session we held at the American Society of Tropical Medicine and Hygiene, people, colleagues, eminent scientists were standing up in line at the end of the presentation, wanting to share their stories about why they were in the field, about a patient when they were a medical student that particularly touched them. So it began to dawn on me that there's something deeper than what we express in our public discourse that motivates all of this outpouring of work. And I think I would say that that is compassion, the desire to alleviate suffering and promote flourishing. Let's look at different views of compassion, different perspectives. The theologian and scholar of world religions, Karen Armstrong, would say that the principle of compassion lies at the heart of all religious, ethical, and spiritual traditions. So it's essential to who we are as human beings. There's a school of ethical thought. Schopenhauer is a good example of this, where regards that compassion is the basis of all morality. How do we respond to suffering? That's will determine the basis of our ethics and our morality. There's an entire science of compassion that has emerged in the last 2 decades, particularly neuroscience, looking at the pathways in the brain that are associated with empathic and compassionate responses to suffering. And a lot of this work has been done with Tibetan Buddhist monks initially, who had thousands and thousands of hours of meditation where they could really observe what was going on in their thoughts and in their minds. And this has led to a series of trainings that are available to all of us now. And we can actually see shifts in our responses to suffering, as well as changes in the neural pathways with relatively short periods of these meditation practices. So there's a whole compassion science handbook that Oxford has produced now. So compassion science, particularly in neuroscience, as something that's emerged in the last 10 to 20 years. And one of the very interesting insights of the neuroscience shows that there are 2 pathways in response to suffering in the brain. When we experience empathy, or we experience the feeling of another suffering, we often can go into empathic distress, where we experience that distress as well. We take it on. And the negative or pain centers of the brain are activated in that. But there's another response to compassion, which has another response to suffering, compassion, which is an other related emotion, the desire to alleviate that suffering. And that is associated with the positive or pleasure centers of the brain. So it's interesting that neuroscience is helping us disentangle these concepts that we often lump together, compassion and empathy. I'd like now to share a composite model built largely on some of the neuroscience observations, but also social psychology, that considers compassion to have 3 main components. And there are some who say there's 4 or 5, and this is kind of a lumpers model of only 3 elements. First, you have to be aware of suffering. There's a cognitive awareness component of suffering. If you're not aware of suffering, you're not going to respond to it with compassion. And then there's an empathic response, a feeling of distress or a feeling of concern that someone is suffering. But compassion doesn't end there. It moves to action, at least the desire to alleviate that suffering. Let's look at this in a little bit more detail. So there's a cognitive attunement, a perspective taking. There has to be a certain stability of mind to recognize suffering. And in clinical care, we recognize that on the basis of someone's expression or how they're holding themselves. In public health, we often have to rely on statistics. We don't have that immediate source of awareness of suffering. We get it through figures and charts and graphs. That, if it's going to lead to compassion, causes an empathic arousal. And this, we feel the suffering of another. And this may not be an intense feeling, but there's an activation of a concern or a feeling of empathic concern related to that person who's suffering. The key here in whether this empathy leads to compassion depends upon emotional regulation. For those of us who are in global health, who might be sitting in front of computer screens most of the time, and then are asked to respond to a public health emergency, say in a refugee camp or an extreme situation, we may be overwhelmed by the suffering that we're experiencing. And we go into personal distress. we don't feel like we're actually able to respond to that suffering effectively. And especially professionally, we feel like that's our role. And so this leads us to a fight, flight, or freeze response, which is more concerned about protecting ourselves than it is about alleviating the suffering of someone else. We might stay in that situation and get really busy, but it's maybe action to alleviate our own distress rather than to effectively and wisely undertake action to alleviate the distress of the person who's suffering. If we can modulate that emotion, and I'd say that chaplains in particular in the healthcare setting are experts at this, being in the presence of suffering, not fleeing, not being overwhelmed, and being able to move to effective action. Then we're able to move into a place where we can take action to alleviate the other person's suffering. There's an added element to this model that is sometimes controversial, and yet I think it's an important one, and that is to not over-identify with the outcome or be attached to it. If the other person's response, if our identity depends on a favorable response or our ability to alleviate that suffering, then we're going to be attached to, our own identity is going to be attached to all of this, and we may not be in control. This element of detachment is about doing what we can in the presence of suffering and not taking on our identity as being the healers or the saviors or the alleviators of that suffering. And this might be something we come back to in conversation. There's usually some objections to this model. It's presented in a linear fashion, and I'd say it's usually not a linear process, but many of these things can be happening all at the same time, and the directionality of the arrows goes in both directions. I'd like to say a few words about challenges to compassion in global health. I've sort of said why it's important and that it's a key motivator, but what are the challenges in particular that we face in compassion, in expressing compassion and actually living compassion in global health? Well, one of them, I've alluded to this already, is that we deal in global health with populations, not with individuals. So the signals of suffering are often remote. They're graphs or figures or charts. We don't see the faces of suffering, to use Bill Foegge's word. And we often work at very great distances, geographic, cultural, economics distances from the people whose health we're working to improve. So there's a lack of immediacy to the reality of suffering and the human dimension of suffering that we deal with in global health. Bill Foegge, former director of CDC and head of the Carter Center when it was first created, gave a speech at CDC many years ago and basically said that if CDC is to maintain its reputation, it'll be because in everything they do, behind everything they say, and as the basis for every program decision, be willing to see faces. He didn't say CDC needed better labs or smarter epidemiologists or new facilities. It was that willingness, even though we're working with populations, to see the faces of suffering, really see them. Another challenge is that we work in complex bureaucracies and partnerships in global health. And I'm not trying to pick on any two organizations in particular here, but many of the organizations we work with have their own dramas, their own internal politics, and they're complex. And particularly young people who are eager to change the world and are motivated by compassion. If their first job is in one of these big bureaucracies, they often come to me and say, boy, I'm just not, this is not fulfilling. This is not what I thought I signed up for. I'm consumed with these internal dynamics and I'm not seeing the effect of the work that I'm doing. And then a third challenge is that we often are at the mercy of, and our work is authorized by governments, political entities, other organizations that may not share our same values. So there are political, economic, and military interests that might, at times, diverge from the core values of global health. And this creates a sense of divided loyalty. A particularly vivid example of this is a publication from the Center for Strategic and International Studies that looks at global health engagement as a tool for the Department of Defense. And the picture on the front cover, which was presented with no sense of irony, is a soldier. You can see his automatic rifle right under his stethoscope. Is this a soldier? Is this a physician? What's actually happening here? And how does that person navigate the divided loyalties in which he's placed? Now, in addition to the challenges, there's a few critiques of compassion in global health that I think are important for us to hear. One is expressed especially by the French physician and philosopher Didier Fassin. He would claim that compassion is an expression of superiority. He says compassion always presupposes a relation of inequality. Particularly in the public sphere, it's directed from above to below, from the more powerful to the more vulnerable. I can be compassionate for you because I'm resourced, I'm a good person, and poor you, let me help you. This is what passes for compassion. And in fact, I think our public expressions and our advertisements of the work we do often slip into this being an expression of superiority, and this can be quite subtle. So I think Fassin, I disagree with his claim, but I take his point to be valid. And this, I would say, is not the compassion that is mature in what we're talking about here. A related critique is that compassion is all about us. We like to talk about how compassionate we are. We use compassion in our mission statements. Some of you might be familiar with this Instagram series of Barbie Savior, which was actually developed by two missionaries who were aware of some of the self-referential language that is often used by particularly short-term mission groups. And I'd say there's a lot of work that's been done to address this sense of particularly in the short-term mission setting, but this is a claim that we need to take seriously. And then a final claim, which was made by Susan Sontag and Paul Farmer, they called compassion an unstable emotion. And in contrast to Schopenhauer, a series of ethicists would say that no, compassion is not the basis of all morality, that ethical decisions and public health decisions should be based on reason. Socrates, Kant, Nietzsche were advocates of this. And they would say that emotions, such as compassion, they would claim, they're a poor basis for public health policy. There's a nice book looking at the statistical lives versus individual lives. And when we see a face, we see an individual, particularly if they resemble us, we're more likely to have compassion and direct public resources to alleviating that person's suffering, rather than becoming aware of the injustices and the suffering that we cannot see. So this stream of thought would say that compassion as an unstable emotion actually promotes inequity and injustice. It's the opposite of what we need in public health. On the other hand, I would argue, in keeping with Roger Haight, in this really nice book, Friends in Conversation, between he and Paul Knitter, both theologians coming from the Christian and the Buddhist perspectives, that to be compassionate for all requires that we be concerned for justice. So compassion and justice are not at opposites. They're not in tension. Actually, compassion can be the fuel, this concern for suffering that motivates the seeking and work for justice. We also have Abhi Bang, who is a physician researcher in Gadchiroli, India, has made major contributions to global health. Abhi would say that global health decisions without compassion become bureaucratic and impersonal and insensitive and even autocratic. So my position would be that there are valid critiques about an immature form of compassion, but to throw compassion out from global health also has some very serious costs. So how do we understand these critiques and how they fit in with what we're promoting or considering here? We often consider compassion to have its opposites or far enemies. These could be cruelty, indifference. There are other sort of opposites. We consider those are not compassion. But there are also near enemies, sentimentality, pity, which come from the place of either sentimentality and lack of engagement, serious action to alleviate suffering, or pity from a place of condescension. These often masquerade as compassion, and I think in global health we need to be aware of when we might be slipping into these near enemies of compassion and seek to ground our compassion in solidarity, in a shared common humanity, and in full awareness of the power imbalances that are often part of the landscape in which we work. There are some real benefits to compassion in clinical medicine that have been described in two recent books in particular. Compassionate care has benefits, measurable benefits for the patient, for the healthcare providers, and for the healthcare system itself. And I would particularly commend Stephen Treziak and Anthony Mazzarelli's book, Compassionomics, to you for an easy read and a survey of these benefits. What about in global health? There are some very interesting signs that have been emerging over the last decade where the need for compassion in global health and its incorporation as something to be attended to, this is happening. In a recent publication, Dr. Tedros, the head of the World Health Organization, was talking about quality of care. And he said, quality of care takes vision, planning, investment, and compassion, as well as these other factors. So the World Health Organization has been looking at quality and the essential component of compassion as something that is needed for quality healthcare. We've collaborated with the World Health Organization to do a series of quarterly rounds, global health compassion rounds, where we've addressed different aspects of global health and the role that compassion plays. And these are available on our FACE website, both the recordings and the reports from these rounds. Several countries, in fact, 7 of them that we're aware of, have included compassion in their national healthcare transformation or quality plans. 2 of them, the major ones that seem to be taking this most seriously, are Ethiopia and Scotland. This is from the health sector transformation plan in Ethiopia, where there's an intentional pillar of the plan to develop a caring, respectful, and compassionate workforce. And a whole series of operational research is now going into exploring, what does that mean? How do you measure it? How do you promote and sustain compassionate care for the workforce? The neglected tropical disease area has been one that I think particularly has grounded itself in injustice, overcoming injustice, and promoting compassion. I think that the NTD area can be considered a mass uprising of compassion in many ways. You have the historic outpouring of compassion care for persons affected by leprosy, the example of Father Damien, the appeals to help, to the description of suffering, the work of people working in NTDs to understand the nature of suffering from these diseases, their social implications, bespeaks an attention and intention to address suffering. And some of the language in the WHO guidelines refer specifically to compassion. So I think there are many other areas of global health, but the neglected tropical disease area is specifically focused on alleviating suffering, not just eliminating transmission of pathogens, but also providing care and compassion to people who have these conditions. We do it imperfectly, but it's part of the ethos. There are many opportunities now increasingly for individuals and groups to cultivate compassion, and this is largely based on some of the neuroscience that I shared earlier. There's a group at the Compassion Institute that's developed a training specifically for healthcare providers, and you can see an example of the 6-week curriculum. This can be given in person or remotely, they've trained thousands of people in healthcare settings in these skills. There's another group that we've been working with, the Center for Compassionate Leadership, that has compassionate leadership and resilience training for global health leaders. And you can see the evidence of the outline of their curriculum on the right-hand side of this slide. There's actually a new cohort beginning in mid-February, and it's still open for enrollment. If you're interested in exploring this, you can check out the link at the bottom of the slide, Center for Compassionate Leadership. I'd just like to stop here. Merci beaucoup. Thank you so much for your attention. I'll turn off the slides. If we need to turn them back on to go back to any of them, I'll be happy to share again, but thank you very much for your attention, and I look forward to our discussion.
David, thank you so much. It's so very rich, what you talked about, and the way you've led us through this. I want to open the floor for comments and questions. Perhaps I can just, as people are thinking, and if you want to put your hand up, we can see your hand, or feel free to put something in the box as well if you're more comfortable that way. I wonder, David, if you could talk a little bit about the relationship between self-compassion and compassion, and coming from the standpoint of people working in global health who've had very busy last 3 years, right? And probably not just global health, but anyone really in the healthcare profession has been absolutely burdened, lots of burnout and overburden. And I wonder if you could just talk about the relationship between self-compassion and compassion, just to get us started.
Thanks, Allison. That's really a key question. And I would say that the experimental and research evidence on that relationship is it's a little bit mixed, but in general, the research suggests that unless we have compassion for ourselves, we're going to be limited in the extent to which we have compassion for others. And I think we see this most clearly in situations where we're overwhelmed, where the workload is overwhelming, where we can't meet the standards that we aim to have, and particularly where our professional identity is linked to being able to alleviate suffering or to do so effectively and to meet the demands. And this is really central to the issue of worker burnout, of overload, of being able to set boundaries. And we always refer to the when you need oxygen mask in the airplane, you put your own mask on first. That's kind of a standard sort of line. But I think there's some truth to that. I think many of us in global health have a strong sense of desire to serve. And I think we can celebrate that we've hitched our identities, professional and personal identities, to our ability to do that. And we also need to attend to our own needs. And I think one of the things that I think is important about self-compassion, or a doorway into that, is recognizing that we also suffer. Particularly in healthcare or public health, we're the helpers. We're the ones that go in and fix things. And somehow to acknowledge that actually we're suffering as well. Seems like if we acknowledge that, we're going to somehow be unable to provide service or alleviate the suffering of others. But the reverse is true. I think we also need to be aware of our own suffering. We may not need to attend to it. If we're a surgeon in the middle of an operation, we might need to pay attention to what we're doing, but we also need to recognize where we are under-resourced, where we need support, and attend to that. Some people object to the use of compassion as a self-directed term, but I think it has a lot of validity. So just like compassion and justice, we tend to think of self-compassion as maybe selfish and somehow at odds or in tension with service to others. I think they're mutually reinforcing. And actually, I would say, Allison, that in the traditional compassion training, in the Eastern traditions, they would actually start with self-compassion, and then it flows out from there. When those trainings were initially brought to Western audiences 20 years ago, they didn't get very far because that was the hardest for us. And so actually it's introduced more along the fourth or fifth lesson now. After you've experienced compassion for others, then you can turn it to yourself. So there's something about our Western psyche that that blocks that awareness or that acceptance that we also need compassion.
Thank you. Manisha, see your hand is up, and then we'll go to Fadi.
Yeah, thank you very much. That was a really insightful presentation. It's really interesting to see the evidence that you lay out in terms of the research that's been done on this, but it also articulates what I think a lot of us just naturally feel when we're doing work in this space. I wanted to get your thoughts on, trends in recent years in terms of, with the public health workforce and the healthcare workforce being so stretched, and your diagram showing how personal distress can lead to inaction. If you see that there's been a trend towards more action or less action over the last few years in global health.
Wow, that's a great question. I think that one thing I didn't mention here is that tension of divided loyalties and being stressed out, and particularly with COVID, the suspicion and undermining of the healthcare provider's role, and particularly public health, the questioning of actually being seen as an enemy by people who are rejecting the support or the help that we're trying to provide through vaccines and other things. That has an effect that is very insidious. And I think then we're venturing into the realm of moral injury and moral distress. And that's where we're feeling like we're in a situation where we know what the right thing is to do, but we can't do it. And somehow then are we participating in the perpetuation of suffering? Are we part of the problem? And it's one thing in the early days of the pandemic when healthcare workers were coming home after their shift and everybody was banging pots and pans and celebrating them. It's a very different picture now. And so I would say that we experience the same thing, particularly in domestic public health. The turnover in public health officials has been massive. We're also experiencing it in global health in other ways. I'll give you my own personal sense. My sense is that there's actually been particularly as the pandemic lifts a little bit, there's been a redoubling of that energy to alleviate our own distress and our own frustration with not having been able to fulfill our professional identities in the way we wanted to over the last 3 years. So there's a lot of activity. I'm really busy right now, and I can't figure it out. So I think there is that kind of a, boy, we need to get busy to kind of reclaim who we are and feel good about the activities that we're doing. Yeah, but I think we also need to attend to this deeper question of moral distress and moral injury that has not been well addressed.
Great, thank you.
Yeah.
Yeah, Fadi, please go ahead. Excuse me if I said your name incorrectly. Please go ahead.
Perfect. You said it perfectly, and thank you for giving me the opportunity to ask a question. I guess it's more of a comment and a question. I really enjoyed your talk, by the way. It's sort of,
thank you.
It's a lot more emotional than most of the talks we go to. So I really appreciated that. I'm a cancer surgeon. We talk a lot about lately another term around compassion that seems to be tossed around is about compassion fatigue, in at least in the surgical space. And you mentioned quality. I was wondering, I'll tell you my take on it, just interested to hear your take. I think some of the times that what we measure as quality or pretend to measure as quality is a bit at odds with compassion. And we boil the conversation down to the individual and whether that individual is compassionate or how the individual is struggling with compassion fatigue or whatnot. But I do wonder at the system level, not just the workforce planning, not just the fact that we're overburdened, whatever, but just even what we prioritize, what we measure, what we pretend to be able to measure and say that's quality care right there. I tell you, as a cancer surgeon, I constantly find that at odds with compassionate care. But maybe that's just my perspective. But I'd be interested to hear your thoughts on it.
Thank you so much. I agree with you completely. And one of the dangers in talking about compassion like I have and saying, oh, here you can go get trained and being resilient is we're putting all of that on the individual healthcare provider, and we're making them somehow tolerate an impossible system better, and we're not addressing these systemic issues. We had a meeting recently of people involved in organizational compassion. And it's interesting that compassion is gaining a lot of traction, and there's a lot of research in the business sector, much more than in the health sector now, because they realize that this affects our bottom line, and it affects how we work as a community or as an organization. And there was a general recognition that organizations might say, boy, we need to bring in some compassion trainers or resilience trainers. We need to support our workforce. And initially that goes pretty well until the people have enough sense of awareness of their own needs, of the brokenness of the system, where they start demanding systemic changes. And at that point, usually the compassion training kind of goes away, and it's the administrators are trying to recover some sense of control and saying, boy, this has gotten out of hand. We can't make these systemic changes because of budgetary or other constraints. And so it's short-circuited. But I agree. I think increasingly, I'm tending to question what are our goals in healthcare, in medicine in particular, and have they, particularly how we measure our success, measure our quality, are we way off track? There's some very interesting research being done on the concept of human flourishing, which kind of goes beyond well-being. And it seems to me that if our goal in medicine is not just to patch people up or to sort of put on Band-Aids, but if we could envision our work as really promoting human flourishing at the individual and societal levels, we would measure what we do differently, we would do it differently. And the thing that I find very challenging is that some of the research that's been cited by Tresiak and Mazzarelli shows that for healthcare systems that have adopted a different approach, a more compassionate, human-centered approach, it's actually good for the bottom line. But I think we're caught in this sort of short cycle need for success in the United States, particularly with for-profit medicine and healthcare. The shareholders want their cut. I think we've gotten ourselves into a system that has really drifted from the aims and the goals of medicine. So I don't have an answer for you, but I really resonate with what you're saying. And I fully agree that one of the challenges with compassion is that it becomes then a tick box on the quality measure. And I think we've seen this with the National Health Service in the UK, which had a big movement towards compassionate care 10 years ago. And you can see what a shambles it's in now, because it was never actually fully supported and it became a tick box. So it needs to be a more fundamental shift in our mindset and our intention of what we're about than just adding a compassion measure or a quality measure that we think is going to fix things. Yeah.
Thank you very much.
Yeah, you're very welcome.
So we have, the conversation makes me think we also need systems that are compassionate for the people working in them. Some of the last couple of questions. There's something from Sydney here in the chat, and Sydney, you're welcome to, I'm happy to read your message here, and if you want to speak to it further, please go ahead. But Sydney writes, you mentioned the bureaucracy of working with different organizations and partners and how the vision and reason becomes lost at times. Through your experience, when you have been in these situations, how do you realign those you are working with and bring the compassion or vision back into practice? And Sydney, if you want to add anything, please feel free. Otherwise, David, over to you.
Thanks, Sydney. That's a great question. And I'd say you have to kind of pick your moments. And I think different audiences are open to different nudges. So for example, I'm a member of the Trachoma Expert Committee, which is sort of a science evidence-based committee that advises Pfizer on its donation of Zithromax for the elimination of trachoma. Over the last few years, those very technical meetings have opened with just a couple minutes of guided reflection and meditation and grounding on why are we here. So that's not going to fly in every professional setting, but I find conversations during the tea breaks and in the hallways to be really fruitful. Not everyone is necessarily open. When you say, how are you? I haven't seen you in a while. They might not really want to talk about how they are. They don't realize that that's the actual question. That is an opening. I find that looking for opportunities to listen, to hear people show up and express how they are. Many of us are carrying, all of us are carrying forms of suffering that are not necessarily being addressed, and we don't really share those. So I think I call them corners, the corners of the meetings, the tea breaks, the conversations over dinner, reflecting on this core question of why are we here? What is it that sustains us? What are the needs that we have to fulfill our intent in doing this work? I find that there's ways to open that conversation, and people are really willing to enter that space when the conditions are right. And I think that leads to kind of a groundswell of understanding and an openness to have that be part of the discourse. So I would guess I would summarize by saying you do it maybe one person at a time, one step at a time. When you're when you're graciously invited to give a talk like this from people like Allison, you say, sure, let me do that. Can we extend the conversation? So I think it's both interpersonal and then seizing opportunities to maybe reflect, even in meetings. Can we go back to our first principles? What are our goals? What's our intention here? Can we align our conversation and our actions so that we're actually in line with the purpose that brought us together?
Thanks, Sydney, for the question, and thank you, David. And just a comment, she said she's in a, or he, sorry, Sydney says, I'm in a loud environment, so thank you for your answer. I love your answer about understanding and openness. So thanks for that. Any other questions or reflections, just as you've listened to the conversation today? It strikes me, David, just thinking, seeing the quote from Dr. Tedros and this inclusion of compassion, you know, from the very top of WHO, and seeing it now enacted and, you know, put into national health plans is really encouraging. And I'm excited that you all are kind of tracking that at face, and it will be interesting to see how it materializes, you know, from plan into action. So I think it's an exciting time, and I guess we can all play a little bit of a role probably in continuing to talk about compassion. It's important. Carol has a comment, Carol Vlasov, who I think you may remember from yeah. So she says she loved your presentation, but wonders about your reference to Paul Farmer. And I don't know, Carol, if you're adding more there. I'll just give it a second.
Oh, yes. Paul Farmer. There's some stories. Paul Farmer embodies compassion. And yet, you know, he worked at Harvard, and he worked at some pretty tough places. And at a meeting we held on compassion and global health at the Carter Center, Paul joined us. And I challenged him, why don't you use the word compassion? He says, if you use that word at Harvard, you get jolted by 2,000 volts of electricity. You know, you just can't do that. And by using that word, there are a lot of people that use compassion in the near enemy sense. They're talking about compiti, or they're talking about it's all about us. And he didn't want to be accused of that, of associating with that. And so he was very deliberately being selective about where he used that word. If you read his conversations with related to liberation theology and its relationship to global health, you see he's all over the word compassion. So I think it's a selective use of the word where it could be understood and accepted. I agree. Paul embodied compassion, and he was talking about compassion in its, I thought, distorted sense as a unstable emotion. That's not the compassion that we're aspiring to and hoping to live by here. Yeah. So thanks for that question for clarification, Carol. I appreciate it. Yeah.
So we're almost at the top of the hour, and I don't see any other comments coming in. Oh, one from James. Okay, James, we'll let you have the last question, and then we'll wrap up. So go ahead, James.
Yeah, not really a question, but a kind of a comment. So when I look, the French philosopher's criticism of compassion, really, it's kind of like interesting to me and quite relevant, especially in the context of global health. Sometimes to be compassionate, there is a huge requirement to also be self-aware of your role in intervening or in providing services in the global context. So when I reflect on the framework for compassion and awareness, on the framework for compassion, I feel awareness should also imply self-awareness. Just not an awareness of the person's suffering, but also the self-aware of your role in in the whole matrix of compassion and your role in global health support, especially with our engagement with partners, with researchers in global health in other countries, and so forth. So I wanted to know your view of extending that model to also include self-awareness, not just awareness of the person suffering.
Thank you, James. You're absolutely right. And I look forward to working on that model with you. I think, without self-awareness, that model just doesn't exist. You're stuck in these distorted sort of near enemies of compassion. So I think, underneath all of that, or somehow represented, that's the starting point, is self-awareness, because we perpetuate suffering and our own agendas and our own projections unless we are self-aware. And I think at the beginning I mentioned that I think global health is actually an excellent school. It's an excellent training in compassion, because we become more and more, hopefully, self-aware of our own role, our own distortions, our own projections. And I think the field of global health demands, if we're going to be successful and we're going to have fidelity to the values of global health, it demands that self-awareness and that continued growth, inner growth as well. So you've sparked some ideas for me. Maybe I'll put together some scratchings on paper, and we can develop that model together. But it's completely missing from the model, other than in that emotion regulation box in the middle. But it's fundamental to the whole model. Thanks for that challenge. It's beautiful.
Thank you.
For those of you who don't know on the call, David is sitting on James's TAC committee, so this will be a fun thing to watch. So thanks for that. It's really my pleasure to say thank you so much, David, for your time today and for sharing your insights with us. And I think it sparked some interesting questions and conversations. And as Fadi said, it's unlike a lot of the other sessions that we've had with p-values and confidence intervals, and so very insightful. And we really appreciate you taking the time today to be with us.